Good morning.
Sir.
Srikanth unnada?
No, sir.
Sir, good morning, sir.
Good morning, Srikanth. Start చేద్దాం శ్రీకాంత్.
Sir, Shekhar Ravi.
One, sir. Sir, start చేయాలా సార్?
శ్రీకాంత్ స్టార్ట్ చేయాలి కదా?
Sir, చెప్పండి sir. చేసే Ravi later.
Morning. Today my topic is on perioperative care of a patient with neurological disease undergoing non-neurological surgery. Most common neurological disorders we encountered are disturbances of consciousness such as delirium and dementia, stroke, epilepsy, myasthenia gravis, and Parkinson's disease. It is crucial in management of medications in epilepsy, Parkinson's disease, and myasthenia gravis. Better understanding of pathophysiological mechanisms helps in avoiding aggravating and relieving factors during management. Example, in Parkinson's disease, dopamine depletion is the antidopaminergic drugs such as metoclopramide cannot be used as an antiemetic. Hence, an alternative medication like ondansetron is used as an antiemetic. Prevention of adverse intraoperative events. Example, patients with proven carotid stenosis at what pressures to be maintained preoperatively can help in preventing ischemic strokes. In evaluation of new neurological changes helps in a preventive preoperative period is necessary. Aware about impact of neurological disorders in anesthetic management, knowing drug interactions in patients on AED is essential. To maintain to normal physiological changes, that is normal hemodynamics and respiratory parameters in perioperative care is useful. Delirium is an acute change in mental status with a fluctuating change from baseline mental status with features of inattention and altered thinking. Post-operative complications of delirium are 1 year mortality rate, incidence is 35 to 45%. Incidence in general surgery 10 to 18%, in orthopedic surgery 53%, in open heart surgery 74%. Post-operative delirium has high associated morbidity and mortality, which may extend up to a decade after surgery. It has several pathological pathways, including neurotransmitter imbalance, neuroinflammation, endothelial dysfunction, and impaired oxidative metabolic and altered availability of large neural amino acids. With such complications, no single intervention is likely to prevent delirium. Key aspects are recognition of delirium, evaluation of delirium, identification of modifiable and non-modifiable risk factors for delirium. Baseline cognitive status should be assessed in preoperative period, particularly in high-risk cases such as cardiac surgery and orthopedic surgeries. Risk factors for delirium are age greater than 70 years. With these patients are having lower neurological reserve. Comorbidities such as stroke, other neurological illnesses, medical comorbidities are noted. Systemic illnesses such as dehydration, malnutrition, abnormal sodium and potassium, abnormal glucose levels, hypermagnesium, blood urea, nitrogen contribute to delirium in perioperative period. Other risk factors are hypoalbuminemia, impaired vision and hearing, active alcohol abuse, depression, and preoperative psychotropic drug use contribute to perioperative delirium. Medications associated with delirium are significant association is present with opioids, antihistamines, benzodiazepines, anticholinergics. Lesser association is associated is seen with tricyclic antidepressants, NSAIDs, dihydropyridine calcium channel blockers, anti-Parkinson drugs. Reversible etiologies are identified and corrected before proceeding to surgery. Etiologies are hypothyroidism, thiamine deficiency, B12 deficiency, infections, medication toxicity, drug and alcohol use, subdural hematomas, normal pressure hydrocephalus, intracranial tumors. Preoperative cognitive impairment or dementia is diagnosed with bedside assessment tools such as clock drawing tasks, telephone interview for cognitive status, mini mental status examination, that is baseline score of less than minimum of 24/30 associated with that is greater than 24/30 associated with increased risk of postoperative less than 24/30 associated with increased risk of postoperative delirium. Recounting the days of the week in reverse is a better tool for diagnosing the predicting perioperative delirium. MMSE is a simple pen and paper test of cognitive function based on a total possible score of 30 points. It includes tests of orientation, concentration, attention, verbal memory, naming, and visual spatial skills. A maximum score of 30 is normal, or above 25 is normal. Abnormal is less than 24. Indicates a possible cognitive impairment. Prevention of delirium. Post-operative delirium can be is prevented and decreased to 30 up to 30 to 40% of patients. Pharmacological interventions are counseling the patients by assessing cognitive impairment and disorientation, deprivation of encouraging more sleep hours, early mobility, correcting visual and hearing impairments, correcting dehydration. Next is perioperative. Intraoperative EEG monitoring likely prevents excessive anesthetic administration to vulnerable patients and prevents postoperative delirium associated with deeper anesthesia. Regional anesthesia is associated with lower incidence of postoperative delirium than general anesthesia. Low dose haloperidol subanesthetic dose of ketamine, perioperative dexmedetomidine help in preventing delirium, perioperative delirium. Dexmedetomidine is more superior, but is not used because of hemodynamic side effects. Treatment is early discontinuation of limb restraint, bladder catheter, early discontinuation of tracheal tubes, invasive lines, surgical drains, and internal tubes may help in preventing delirium, as they may cause unnecessary discomfort and aggravation of agitation in patient. Antipsychotic medications are frequently used. Post-operative analgesia is another challenge, as many analgesia medications can precipitate delirium. Non-sedative analgesics and regional anesthesia should be considered. In patients with severe post-operative pain, opiates alleviate both pain and delirium. Stroke. Risk of morbid mortality is 26%. Incidence is 0.1 to 1.9%. Perioperative stroke causes are hemorrhage, air embolism in particularly surgeries with sitting position, as in shoulder surgeries, fat embolism in orthopedic surgeries. Weaning of bone is involved soon after release of tourniquets. Fat embolism chances are more. Paradoxical embolism has occurred through patent foramen arterial dissection during nerve manipulation while positioning may also cause vessel manipulation while positioning may also cause perioperative stroke. Risk factors are nature and timing of the procedure, presence of atrial fibrillation, hypercoagulability syndrome, female sex, renal insufficiency, pulmonary disease, preoperative discontinuation or continuation of antithrombotic therapy, Cardiac surgeries and carotid endarterectomy pose higher risk for perioperative strokes, with an incidence reaching 8% for combined procedures. CABG and valve surgery and in contribute to 13% of patients risk. Stroke following non-cardiac, non-vascular, and neurological surgeries has significant lower incidence. Potential modifiable risk factors are carotid artery stenosis with symptomatic patients. Treatment is endarterectomy only. Revascularization is considered in patients with asymptomatic carotid artery stenosis before or during major cardiac or vascular surgeries. In asymptomatic patients with carotid stenosis, preoperative evaluation by doing brain imaging to diagnose silent ipsilateral infarcts. Preoperative identification of intra-aortic atherosclerosis plaques is done by using in patients posted for cardiac surgeries. Perioperative discontinuation of antithrombotic therapy should be considered within 6 hours post-operatively. Should continue anticoagulation can be continued for minor procedures. INR of 1.8 to 2.1 is safe and effective. Hence, continue anticoagulant therapy with a target of up to INR up to 2.1. For more invasive procedures, bridge therapy using IV heparin started by withholding warfarin. With bridge therapy, instance of stroke is perioperative stroke is 0%. Without bridge therapy, incidence of perioperative stroke is 0.6%. Perioperative stroke is defined as a cerebral infarction of ischemic or hemorrhagic origin occurring during or after surgery, with post-operative time period sometimes defined as up to 30 days. Cardiac surgery and detailed history with specific questions on previous unreported, unrecognized, or inadequately evaluated cerebrovascular symptoms within past 6 months period should be asked. Medical management of other risk factors such as hypertension, diabetes, and hypercholesterolemia should be optimized. Preoperative ischemic stroke may be eligible for intravenous thrombolysis, intraarterial preoperative ischemic stroke may be eligible for intravenous thrombolysis. Intraarterial thrombolysis can be used either alone or in conjunction with intravenous thrombolysis, and may be safely administered in patients with within 6 hours of symptoms onset. They may also be candidate for mechanical thrombectomy within 8 hours of symptomatic onset if National Institute of Health score scale is greater than 7, or if there is a contraindication for thrombolytic therapy. Current AHA guidelines, major surgery within 14 days of stroke is contraindication to intravenous thrombolysis. Patients with minor surgery done at a site where bleeding can be controlled with compression may still be considered for thrombolytic treatment and mechanical thrombectomy post-operatively. Seizure disorders. Epilepsy have a high perioperative morbidity either due to epilepsy disease itself or associated comorbidities. Stroke is the post-operative complication in patients with epilepsy. Neurological consultation is needed prior to surgery for titration of anti-epileptic drugs. Anti-epileptic drugs should consume in the morning with sips of water. AED should be reinitiated as soon as feasible after surgery. AED is interact with other medications. Patients on warfarin, INR should be monitored perioperatively. Optimization of AEDs interact with other medications that are used in perioperative setting. Patients on warfarin should have the titrated INR. Commonly as affected medications classes are antihistamines, antibiotics, immunosuppressants, beta blockers, calcium channel blockers. Cytochrome P450 activity inductors are phenadine, phenobarbital, carbamazepine, oxcarbazepine. They decrease the efficacy of other drugs. Cytochrome P450 inhibitors such as valproate, they increase the efficacy of other drugs. Side effects of valproate are thrombocytopenia, inhibition of platelet aggregation, reduction of 1 millibrand factor, fibrinogen depletion. Hence, the stock of platelets clotting factor should be in reserve prior to surgery. In patients, epileptic patients, sometimes on advice of ketogenic diet. Ketogenic diet is a type of treatment for epileptic patients. Patients should be given carbohydrate-free solutions. Hence, electrolytes should be electrolytes, glucose, and pH should be monitored as patients are at risk of perioperative acidosis. Causes of seizures in perioperative in patients are epilepsy. Epilepsy is a breakthrough seizure. Risk factors are poor seizure control, frequency, increased frequency, timing of last seizure, subtherapeutic drug levels of the anti-epileptic drugs, sleep deprivation. Anesthetic drugs such as act as in high hypnotic anesthetic drugs in hypnotic doses act as proconvulsants or anticonvulsants, sometimes as anticonvulsants, depending on the drug dose of physiological situation of the patient. Preconvulsant effects of drugs seen more in epileptic patients than in non-epileptic patients. Local anesthetic systemic toxicity and meperidine in large doses require trigger seizures in patients on monoamine oxidase inhibitors. Toxicology screen is necessary. Toxicology screen is necessary to rule out consumption of drugs. Neurosurgery itself, metabolic and systemic derangements should be ruled out, such as hyponatremia, as in transurethral surgery, hypocalcemia in thyroid or parathyroid surgery, in patients with infections of sepsis, hypoglycemia, acute organ failure, and malignant hyperthermia should be ruled out. Drugs and alcohol withdrawal toxicology screen is ruled out. Alcohol withdrawal causes generalized tonic-clonic convulsions within 2 to 48 hours of abstinence. Other causes of seizures in perioperative patients are intracranial cerebrovascular surgery, and surgery itself causes a stimulation of seizures because of excessive degree of brain retraction, location of the defect, pathology. Perioperative stroke may be ischemic or hemorrhagic stroke. Evaluation of new seizure. Etiology is general anesthetics, local anesthetic toxicity, drug or alcohol withdrawal, intracranial surgery, screening for electrolyte abnormalities. Acute seizure management is a timeline chart. In the first 5 minutes, first line agents are lorazepam with a dose of 0.1 mg per kg IV with maximum 4 mg. Repeat once in 4 minutes, or other drug is midazolam 10 mg IM once. In next 10 to 15 minutes, second line agents are levetiracetam or phosphonidine or valproate. Advanced airway management using rapid sequence induction, bag wall mask ventilation, induction with propofol or ketofol, paralytics used are rocuronam or sugammadex is available. Then in 15 to 20 minutes, refractory medications in status epilepticus such as propofol, midazolam, ketamine, lacosamide are used. Neuromuscular disease. Most common complication is seen with neuromuscular disease is respiratory weakness. During physical examination, inspection of axial respiratory muscle use and diaphragmatic extraction and auscultation of lungs for any additional sounds, functional assessment of functional vital capacity with spirometry, pulmonary function test and ABC are helpful in predicting pulmonary complications after surgery. Muscular dystrophy and undergoing scoliosis surgery with forced vital capacity less than 40% are prone for respiratory complications. CPAP and BiPAP have demonstrated in these cases. Risk stratification for neuromuscular weakness. Chronic respiratory weakness, precipitating carbon dioxide narcosis in severe cases. NIV is useful to decrease the excessive respiratory distress. Bulbar weakness, dysphagia, swelling, and difficulty in swallowing causes are more decrease is a bad prognostic indicator for surgery. Anesthetic considerations are facial hereditary neuropathy with liability pressure palsy. Hence, careful position, surgical position is kept to avoid pressure injuries. Autonomic dysfunction should be checked as changes in vitals occur intraoperatively. Aminoglycoside antibiotics prolong neuromuscular transmission. High dose steroids causes critical illness myopathy. Early mobilization in the perioperative period, early mobilization is encouraged. Combination of bulbar and respiratory weakness increase the risk of aspiration pneumonia. Non-depolarizing neuromuscular blocking agents prolong neuromuscular blockade. Theoretically, at risk of these patients are at risk of hyperkalemia with the use of succinylcholine. There is cardiac involvement, either it is congenital involvement or abnormality or cardiac dysfunction. So preoperative cardiac assessment using ECG, echo and continuous cardiac holter monitoring. Incidence of pulmonary complications in patients with myotonic dystrophy and comorbidities is 8.2%. Myotonic dystrophy, anesthetic considerations. The myotonic reaction in which muscle rigidity occurs. Treatment is phenytoin 4 to 6 mg per kg per day or quinine 0.3 to 1.5 grams per day. Patients are sensitive to certain anesthetics and muscle relaxants such as succinylcholine, methotrexate, etomidate, propofol, and neostigmine. Because of atrophied smooth muscles, these patients are presented with as interstitial pseudo obstruction in the perioperative period. Myasthenia gravis considerations, anesthetic considerations, risk stratification. There is chronic respiratory weakness developing carbon dioxide narcosis in these patients. But these patients are mostly posted for thymectomy cases. After thymectomy, disease remission occurs. Sometimes immunosuppressants are used to remit disease. Myasthenic crisis under prolonged ventilator use is common in severe cases. Continue anticholinergics and immunosuppressants postoperatively. Azathioprine and immunosuppressant prolongs succinylcholine action, inhibits non-depolarizing muscle relaxant action. Postoperatively, myasthenic gravis patients stabilized with pyridostigmine. It is an anticholinergic agent. There is a decrease in neuromuscular blocking agents action because of pyridostigmine. So volatile anesthetic agents are safe in these myasthenia cases. Early starting of pyridostigmine perioperatively, oral or its parenteral equivalent is preferred. boosting dose of IV methylprednisolone prior to extubation helps in early recovery. Medications that trigger myasthenia gravis are antibiotics such as aminoglycosides, fluoroquinolones, macrolides, penicillin, non-depolarizing neuromuscular blockers such as pancreonum, vecuronium, atraquium, beta blockers such as propranolol, atenolol, metoprolol, antiarrhythmic drugs such as procainamide, quinidine, local anesthetics such as procaine, xylopine. Other drugs are magnesium. Malignant hyperthermia syndrome is it is characterized by muscle rigidity, fever, and cardiac arrhythmia. It is an autosomal dominant inherited calcium channel gene defect. Halothan and depolarizing muscle relaxants precipitate malignant hyperthermia syndrome. Masseter contractures, muscle rigidity with fever, acidosis, and tachycardia are the characteristic features. Parkinson's disease and anesthetic concentrations. Parkinson's disease is a severe neurodegenerative disease. Multiple medications are patient presents with multiple medications at the time of surgery. Patient is having dual presentations either in on state or off state. In off state, patient moves easily with coriform dyskinetic movements. In off state, patient is bradykinetic and rigid. Patients sometimes are having a deep brain stimulator posted to diagnose the condition of the patient. MRI scan is done with less Tesla 1.5 T system. In MRI, brain tissue heating and edema occurs at the electrode while doing MRI. Hence, patient should give information to the technician to assess device malfunction. During MRI, deep brain stimulator should be turned off by taking the assistance from the company manufacturer. Anesthetic considerations in Parkinson's disease are timing of Parkinson's disease medication is of more importance. Abrupt cessation of levodopa causes hyperpyrexia syndrome. To prevent relapses, levodopa medication is replaced with another dopaminergic agonist such as transdermal roticotin. Monoamine oxidase inhibitors such as selzilin, rasigilin with meperidine or dextromethorphan causes fatal serotonergic syndrome. Discontinuation of all monoamine oxidase inhibitors at least 3 weeks prior to surgery doesn't cause a rebound or withdrawal phenomena. Post-operative care in patients with Parkinson's disease. There are concerns of post-operative swallowing, urinary tract infections, post-operative delirium. In patients with post-operative swallowing, avoid anti-emetic medications with antidopaminic effects such as metoclopramide, and other alternative is ondansetron. Urinary tract infections, aspiration pneumonia, and bacterial infections are treated accordingly. Sir, అయిపోయింది సార్. సార్
The topic is open for discussion.
శేఖర్ మాట్లాడు.
Sir, so topic is open for discussion.
Good morning, Ravi. How do you manage a patient presenting with seizures and having acute alcohol withdrawal?
సార్ మళ్ళీ ఒకసారి అడగండి సార్, ఫస్ట్ కట్ అయింది వాయిస్.
Acute alcohol withdrawal presenting with seizures.
సార్
What
ట్రీట్మెంట్
drug you will give?
లెకోసమైడ్ సార్,
Huh?
లెకోసమైడ్.
No. you should give optineuron or thiamine first
Thiamine.
before giving anticonvulsant.
Okay.
Hello, Dr. Ravi.
Madam.
You told about Parkinson's on state, off state. Please
Madam.
explain that one.
Madam, when there is a normal levels of dopamine levels, normal movements will get normal, madam. When there is deficiency, counter contractures of muscles will occur, so movements will get rigid and sharp movements.
Ravi,
Sir,
how will you detect intraoperative seizures in a patient under GA?
sir.
How will you detect intraoperative seizures in a patient under GA?
Raised ETCO2, sir.
Raised ETCO2.
GTCS seizures, sir. Generalized
Intraoperative seizures in a patient undergoing craniotomy under GA.
under the. Sir, EEG changes, sir. Which
What will be the EEG changes?
sir, increased alpha waves, sir.
Oh,
Increased alpha waves.
and
Sir, alternate alpha and theta waves, sir.
okay. How will you prepare for a patient having myasthenia gravis going for GA?
Sir, first
Shekhar, PSC preparation investigation, sir, or the patient preparation?
Preoperative evaluation and management, sir.
Sir, first we'll take the history of previous respiratory compromise complications, breathing, then any hospital admissions, then assessing further with ABG, any compromised respiratory component, then pulmonary function test. Inspection of the patient, any uses of axial respiratory muscles, then treatment history, doses of anticholinergics, then any recent aggravating factors causing plasmapheresis or IV immunoglobulin infusions. Any gland abnormalities at the level of neck, thymus gland abnormalities. Other associated immunosuppressive diseases, history of diseases.
Hello, good morning, Ravi.
Sir, good morning, sir.
Small question. For what neurological conditions, say most of say ortho people, they will be having some sort of either neural issue or else convulsions issue or long-standing anti-psychotic medications. I mean to say elderly people with hip fractures, they all come. Okay, so if the patient is having a history of convulsions around 3 weeks back, how will you proceed? And a patient with history of 1 week back convulsion, how will you proceed?
Sir, first I will ask the duration of seizure episode, then frequency of episodes.
So what will be your plan of anesthesia for say hip fracture or a femur fracture, IT fracture with history of convulsions? He fell with episode of convulsion and he had fractured his leg. How will you handle this case?
Yes, sir. I will go for CT brain. Is there any history of infarcts, undiagnosed infarcts? Then titration of anti-epileptic medications, and I'll advise continuation of medications, anti-epileptic drugs with sips of water on the day of surgery itself. I will find out the triggers of seizures, and I will try to optimize the triggers.
Go on. ఎందుకు ఆగారు? Optimize తర్వాత. I
3 weeks, 1
asked you,
week.
how will you handle this case?
3 weeks, 1 week అనేది plus.
Recent history of convulsions ఉంది. So you started anti-epileptics, and what next? You took the case or no?
Yes, sir, I will take the case. Sir, first neurological assessment should be done, sir, whether there is any other comorbidities.
Okay, you have done, there is nothing but the only history of convulsions.
Easy.
Okay, EEG you have done. Inka?
Ravi,
Sir,
he wants to know whether you prefer GA or spinal. If history of 1 week is there, you go for GA.
okay, sir.
That answer you should tell.
Okay.
Yes, sir. అదే అడుగుతున్నానండి. అంటే ఇప్పుడు 1 week ఉంది, హిస్టరీ రీసెంట్ గా ఎపిసోడ్ ఉంది. What will you do? That's what I'm asking. You did EEG, everything. What next? Will you take the case or not? I'm asking. Okay.
Sir.
Ravi, what are the drugs available in the OT anti-seizures?
Benzodiazepine, short-acting benzodiazepine, ultra short-acting barbiturate, thiopental. Sometimes diazepam also will give, madam. Lorazepam, dose of 4 mg. Propofol. Etomidate in high doses acts as anticonvulsant, madam. Ketamine in high doses also cause deep burst stimulation. It acts as anticonvulsant. Phenytoin and phosphenityne.
Don't dwell, there was controversial points in exam. Ketamine high doses anti. It is the last drug to be used in status epilepticus.
Sir.
Don't tell such answers and give your hate to the exam.
Okay.
How do you identify the myasthenia crisis?
Madam, cut in, madam, voice.
Myasthenia crisis.
Madam wants to know the difference between myasthenic crisis and cholinergic crisis.
The cholinergic crisis, only overdose of anticholinergics are at the time of reversal, we can identify, sir. Myasthenic crisis will diagnose with the help of hydrophonium test, penicillin test. Hydrophonium is a short-acting anticholinergic, madam.
How do you know this patient got myasthenia crisis or a cholinergic crisis? What are the symptoms you can say? Symptoms or signs?
In cholinergic crisis, symptoms of sludge will be there, madam. Excessive salivation, lacrimation, urination, bowel distension. In myasthenic crisis, the patient is having very flaccid body, respiratory compound, both respiratory compound. In cholinergic crisis, body will be rigid, madam.
In myasthenia, patient have tachycardia, pupils are normal, muscles are weak. In cholinergic is brady and pupils are constricted.
Ravi, you told the post-thyroidectomy hypocalcemia is a complication, no? How do you test for hypocalcemia bedside?
The Chowstick sign, sir, with an inflating BP cuff above systolic blood pressure consistently for 5 minutes or 1 minute, sir. There is spasm of carpophalangeal joint, sir. At the wrist also contractions, sir.
Which is more dangerous, bilateral laryngeal nerve palsy or unilateral recurrent laryngeal nerve palsy?
Sir, bilateral ఏమన్నా సార్? క్వశ్చన్ అర్థం కాలేదు సార్. Bilateral ఏమన్నా?
Because striator is a complication for unilateral. Sorry, partial or complete recurrent nerve. Bilateral incomplete,
Sir.
bilateral complete.
Sir.
Bilateral incomplete లో striator వస్తుంది, bilateral complete లో
కంప్లీట్ గా
Ravi,
Sir,
what is Chostek's sign? What is Chostek's sign?
sir, contracture of palms, hands, sir, when inflate BP cuff above systolic pressure.
Really? Is it? Chostek's is facial tick.
Okay.
What you are saying is Trosh's sign.
Yes.
Ravi, what is Miller-Fisher syndrome? It is involvement of third, fourth, sixth nerves in Guillain-Barré syndrome. ఇది eclampsia include చేయలేదు రవి ఇది నువ్వు.
Yeah, he didn't include eclampsia. How will you differentiate patient with eclampsia seizures and patient having seizures coming for normal delivery?
History, sir. History of hypertension during pregnancy.
Okay. What are the components that you will take care? I mean, you will assess in the history.
Lab parameters, sir, proteinuria, pedal edema.
I am saying history.
అదే సార్ హిస్టరీలో హెడేక్, ఫ్రీక్వెంట్ proteinuria, వీక్లీ కన్సల్టెన్స్ లో సైక్లికల్ చూస్తాం కదా సార్, పెరిడల్ ఎడిమా, ఎక్సెసివ్ వెయిట్ గెయిన్. అదర్స్ ఇదర్స్.
How do you treat seizures in eclampsia?
సార్ మెగ్నీషియం సల్ఫేట్ సార్.
Dose?
Sir, 40 grams, sir, 5 in each butter, then 4 grams in IV, sir. Then Arcamin, sir, Lebetlol to control BP, sir.
What is the drug of choice to control BP in preeclampsia?
Lebetlol, sir.
Why?
Sir, alpha methyl lopa, clonidine, Lebetlol, sir.
Methyl-dopa we are not using these days. Okay. So why labetalol? What is the criteria for using labetalol in preeclampsia? If an eclamptic patient develops pulmonary edema,
Sir,
then what is the drug of choice for controlling the hypertension?
100 micrograms.
100 mics of what?
Artemethyl, alpha methyl dopa.
Alpha methyl dopa is not used in all the patients. Okay. What is the second line drug that should be used in preeclamptic hypertension, uncontrolled hypertension?
Record here, record, sir.
Nifedipine, sir.
Dose of nifedipine?
$30 to $120 mg, sir, per day, divided.
If you want to control the hypertensive crisis, what should be the dose of nifedipine and how will you give?
Sir, sublingual nifedipine, 10 mg. Sir,
Okay.
Hello, Ravi.
Sir.
Sir. Hello.
sir.
Sir. Last time ki ఇప్పటికి మీ క్లాస్ లో చాలా డిఫరెన్స్ ఉంది సార్. బాగా వర్కప్ చేశారు, ఇంకా వర్కప్ చేయండి. ఆల్ ది బెస్ట్.
Thank you, sir. Madam?
Oh, actually, we should never mention about sublingual nifedipine, okay? That
Okay.
is not at all used nowadays because of we have drugs which can be given IV infusion or IV post doses. Don't mention about sublingual nifedipine.
Okay.
Anytime we are not all giving doses.
Madam, voice cut out, madam.
హలో రవి,
Madam, good morning, madam.
మార్నింగ్. మేడం చెప్పేది ఏంటంటే సబ్లింగ్వల్ నెఫిడిపిన్ అనేది జస్ట్ ఇమీడియట్ గా ఇస్తాం కానీ ఇట్ డజంట్ సాల్వ్ ద ప్రాబ్లం. రీబౌండ్ హైపర్ టెన్షన్ వస్తుంది, టెకికార్డియా వస్తుంది. సో ఎనీవే ఫాలోయింగ్ దట్ యూ హ్యావ్ టు స్టార్ట్ సమ్ ఐవి ఇఫ్ ఇట్ ఈస్ వెరీ హై బ్లడ్ ప్రెషర్ రిఫ్రాక్టరీ. And then you have to start infusion, probably labetalol అలాంటి infusion start చేయాలి. Only if you say just one sublingual dose of nifedipine, that's not good enough answer. ఇంకొకటి myasthenia కానీ ఎనీ మస్కులర్ డిస్ట్రోఫీస్, మస్కులర్ డిజార్డర్స్ వీళ్ళందరికీ నువ్వు పిఎస్సిలో తప్పకుండా పల్మనరీ ఫంక్షన్ టెస్ట్ చేయాలి, వైటల్ కెపాసిటీ, మాక్సిమం ఇన్స్పిరేటరీ, ఎక్స్పిరేటరీ ప్రెషర్స్, ఫోర్స్ అవన్నీ చెయ్యాలి. ఎందుకంటే దే విల్ ప్రెడిక్ట్ యూ వెదర్ దట్ పేషెంట్ విల్ నీడ్ మెకానికల్ వెంటిలేషన్ లేటర్ ఆర్ నాట్ అనేది మనకు ఐడియా వస్తుంది. సో నీ ఆన్సర్ లో అది మెన్షన్ చేయాలి తప్పకుండా, పల్మనరీ ఫంక్షన్ టెస్ట్ న్యూరోమస్కులర్ డిజార్డర్స్ వాళ్ళల్లో. ఓకే, ఇంకొకటి ఇన్ న్యూరలాజికల్ కేస్ ఫర్ నాన్ న్యూరలాజికల్ సర్జరీస్ అలాంటి వాటిల్లో వాట్ ఆర్ ద న్యూరలాజికల్ డెఫిసిట్స్ అనేది నువ్వు తప్పకుండా డాక్యుమెంట్ చెయ్యాలి. ప్రీ-ఆప్ న్యూరలాజికల్ డెఫిసిట్స్ డాక్యుమెంట్ చెయ్యాలి. సో యూ డోంట్ గెట్ ఇన్ టు లీగల్ లిటిగేషన్స్ పోస్ట్ ఆపరేటివ్. ఒక్కొక్కసారి వాళ్ళు ఆర్గ్యూ చేస్తారు, ఆపరేషన్ కి ముందు ఈ వీక్నెస్ లేదు, అది లేదు, తర్వాత వచ్చింది, సో దిస్ ఈస్ బికాస్ ఆఫ్ యువర్ అనస్థెటిక్ టెక్నిక్, వాట్ ఎవర్ ద రీజన్ అలాంటి. సో మనం నోట్ చేసి పెట్టాలి, ఈ వీక్నెస్ రెసిడ్యుయల్ ఇది ఉంది, అది ఉంది, ఈ ప్రాబ్లమ్స్ అన్ని. అండ్ న్యూరోపతీస్, న్యూరలాజికల్ డిజార్డర్స్ వాళ్ళకి సెన్సరీ లాస్ అలాంటి వాటికి నువ్వు యాజ్ యూ మెన్షన్ పొజిషనింగ్ అండ్ ప్రెషర్ సోర్స్ అవి రాకుండా అదంతా ప్రికాషన్స్ తీసుకోవాలి ఇంట్రా అండ్ పోస్ట్ ఆప్ లో కూడా. ఓకే, సో అండ్ టెస్ట్ ఫర్ ఆటోనామిక్ డిస్ఫంక్షన్ అవి మెన్షన్ చేయాలి నువ్వు. ఆటోనామిక్ డిస్ఫంక్షన్ ఉన్న కండిషన్స్ లో ఇన్ యువర్ పిఎస్సి ఆటోనామిక్ డిస్ఫంక్షన్ లో ఏం టెస్ట్ చేస్తావో అది మెన్షన్ చేయాలి ఎగ్జామ్ లో. న్యూరలాజికల్ కండిషన్స్ లో డిపెండింగ్ ఆన్ యువర్ క్వశ్చన్ యువర్ ఆన్సర్ షుడ్ బి ఫ్రేమ్డ్. అంటే ఫస్ట్ ఆ కండిషన్ లో ఏంటి పాథోఫిజియాలజీ ఏంటి, ఏంటి ప్రాబ్లము, వాట్స్ ద ట్రీట్మెంట్, దాన్ని బట్టి నీ ఆన్సర్ కూడా ఉండాలి. ఓకే, జనరలైజ్డ్ అలాగా చెప్పేసేయడం కాదు, నీకు హోల్ టాపిక్ ఒక క్వశ్చన్ ఆన్సర్ కాదు ఎగ్జామ్ లో. ఈచ్ థింగ్ వాట్ యూ సెడ్ ఈస్ ఈచ్ వన్ ఈస్ ఈచ్ క్వశ్చన్ అది. సో అందులో పిఎస్సిలో లైక్ వాట్ ఆర్ ద ఆప్షన్స్ ఫర్ యూ, ఏ అనస్థీసియా ఇవ్వచ్చు ఈ కేసుకి, జిఏనా, రీజనలా, లేకపోతే బ్లాక్సా, ఏది ఇవ్వడానికి ఏంటి ప్రాబ్లము, విచ్ ఈస్ సూటబుల్, విచ్ ఈస్ ఇండికేటెడ్, విచ్ ఈస్ కాంట్రా ఇండికేటెడ్, అలాంటివన్నీ నువ్వు చెప్పాలి, అవన్నీ కవర్ చేయాలి. అండ్ నువ్వు స్ట్రోక్ కేసెస్ చెప్పావు, స్ట్రోక్ లో వాళ్ళ యాంటీ ఎపిలెప్టిక్సే కాకుండా నువ్వు చెప్పాల్సిన స్ట్రోక్ కేసెస్ లో చాలా మందికి యాంటీ ప్లేట్లెట్స్ మీద ఉంటారు వాళ్ళు. ఇఫ్ ఇట్ ఈస్ ట్రామా కేస్ ఇమీడియట్ గా చేయాలంటే ఏంటి ఆప్షన్, ఏంటి చాయిస్ ఆఫ్ అనస్థీసియా. ఇఫ్ ఇట్ ఈస్ ఎలెక్టివ్ కేస్ వాళ్ళకి ఏంటి బ్రిడ్జ్ థెరపీ, ఏంటి ఎన్రోల్ స్టాప్స్, ఇవన్నీ కూడా అందులో వస్తాయి. స్ట్రోక్ అంటే స్ట్రోక్ లో వాళ్ళు ట్రీట్మెంట్ బట్టి ఉంటది కదా నీ అనస్థీసియా. సో అవన్నీ కవర్ చేయాలి అలాగా. ఓకే, అండ్ కార్డియో ఎంబాలిక్ స్ట్రోక్ ఉంటారు వాళ్ళు కూడా, వాళ్ళకి యాంటీకోగులెంట్స్ మీద ఉండొచ్చు. ఓకే, లేకపోతే హెమరేజిక్ స్ట్రోక్ ఉన్న వాళ్ళు ఉన్నారు, వాళ్ళలో అదర్ సర్జరీస్ ఎన్ని రోజుల వరకు యూ వాంట్ టు అవాయిడ్, ఐసీ బ్లీడ్స్ వాళ్ళలో. ఆల్ దీస్ యూ హ్యావ్ టు కవర్. ఓకే, ఫైన్, థ్యాంక్ యూ.
Thank you, madam. Shall we conclude? Any further questions, or we will conclude the session?
Okay, Shekhar and Ravi, thank you.
Thank you, madam. Thank you very much.
మేడం ఇదేనా అవసరం చూడండి.
Thank you, Ravi. Thank you, Shekhar.
Thank you, Shekhar.
థ్యాంక్ యూ సార్.
Thank you, Srikanth.
Thank you to all.
Assign and leave and everything. Assign and leave and. Huh?